see. Okay. So why are we doing ultrasound? Hey, because it's inexpensive, does not require sedation, reproducible, there is no eye noising radiation, it is suitable for screening, and it allows bedside application. This is the superiority to MRI. You can do it at bedside. You don't need to sedate the patient. And this beats the CT, this beats the MRI. There are many indications, as you can see here: HIE, hemorrhage, PVL, hydrocephalus, infarction, sinus thrombosis. You can make the diagnosis of congenital anomalies, infections, tumors, vascular anomalies, even craniosynostosis. Even you can make the diagnosis of patent ductus arteriosus by looking at the cranial images. Cranial ultrasound images in the heart, in the mediastinum. But so I'm going to focus on the most common ones, but I will show you some examples for the other indications as well. The technique is a little bit challenging compared to abdomen because you are doing it bedside in the NICU, and you need to make sure that the patient is stabilized. You need to clean, make sure that the probes are cleaned and you're not transmitting infection. And as you can see here, the orientation is different because you can be on the right side of the patient or left side of the patient, or you can be doing the ultrasound from the foot or from the head. So the orientation is difficult. So when you first try to do it, you need some time to learn the orientation. But afterwards, it's simple. We are using the anterior and mastoid fontanelles routinely, and we use the additional fontanelles if needed. Here, you can see the probes. We are using a convex probe or a microconvex probe. Also, this is called phased array probe or sector array probe. You can use this. This is lower resolution, but you can see the deep structures better. And always we use a linear probe as well. This is higher resolution, but you can't see the deep structures. So for a neonate, like for a preterm neonate, this might be enough, but the term, you need to see the deep structure. So we need both of them. And we are doing the ultrasound in the neonate, but if the fontanelle is open, you can always do it at an advanced age up to if the fontanelle is open. But if you're doing in a 4-month-old, the images will be limited, as you can see here. That because of the hair, because of the small fontanelle, images will be limited. Very good. And the resolution will be poor, but still it will be enough to exclude the hydrocephalus, for example, a major anomaly. But the role of ultrasound is to exclude major anomalies. It's not like an MRI, you see very detailed pathologies. So this is the anterior fontanelle, posterior fontanelle. That's the mastoid fontanelle, pterian, and the squamosal bone. It's very thin, so it allows to scan the brain through the bone. So, or even you put your probe somewhere here, because the bone is thin, you can see the brain through it. It's anterior and mastoid are routine, but you can use any defect in the skull. These are basic images. We need to get at least 6 images through the anterior fontanelle in the coronal plane first. Frontal lobes, you're swiping your probe from anterior to posterior, you get the images. Usually our sonographers get a cine clip from anterior to posterior. And then in the sagittal plane, we do the imaging midline, mid-sagittal, and then, do you have a chair? So, and we get parasagittal images as well from the right side, from the left side. And that was from the anterior fontanelle. The mastoid fontanelle allows assessment of the posterior fossa nicely. So it is right behind the ear. You put your probe, you get oblique coronal views, and I put the MRI correlation here. Oblique coronal views, it's basically for cerebellum and posterior fossa structures, at least 2 images, including the fourth ventricle. And for example, you can see the third ventricle here, fourth ventricle here, and you can see the aqueduct of Sylvius nicely, which is very tiny, and you can see even tiny clots by using ultrasound here. Transchromosal approach or Piterian approach allows axial images, just like CT or MRI. And this is the ultrasound image, and this is MRI correlation. And here is the circle of Willis on the axial plane. This is also very nice, but it's not routine. And for the anatomy, if you put your probe anteriorly, you will see the interhemispheric fissure. That's the MRI correlation, frontal lobes. And then if you swipe a little bit posteriorly, you start seeing the frontal horns of the lateral ventricles and the cavum septum pellucidum here. That's the MRI correlation. That's the corpus callosum as a hypoechoic structure. And head of the caudate nucleus, there's a body and tail of the caudate nucleus as well. We are just seeing the head and the putamen, a little bit in the lateral aspect, Sylvian fissure, and then a little bit posteriorly, we start seeing the body of the lateral ventricles, interhemispheric fissure, corpus callosum, hypoechoic, and third ventricle. This is not third ventricle, this is the third ventricle down the lateral ventricles, Sylvian fissures. And if you use, that was the convex probe. If you use a linear probe, your resolution will be better and you can see the structures nicely. And the third ventricle can be better seen, as you can see here. And the lateral ventricles and the corpus callosum. And that's the cingulate gyrus, just over the corpus callosum. Interhemispheric fissure here, and head of the caudate nucleus, and the cavum septum pellucidum. And if you swipe a little bit more posteriorly, you'll see the posterior aspect of the body of the lateral ventricles. Here, interhemispheric fissure, thalami, bilaterally, tentorium cerebelli as an echogenic structure, cerebellar hemispheres, cerebellar vermis, and then a little bit posteriorly, we start seeing the choroid plexus and the parietal lobes, choroid plexus, and then we start seeing the occipital lobes, and in the mid-sagittal plane, frontal, parietal, and occipital lobes, and hypoechoic structure is the corpus callosum, and cingulate gyrus right over the corpus callosum, the third ventricle in the midline, and the fourth ventricle, and the brainstem, and the cerebellar vermis. It appears echogenic normally. And if you swipe paralateral, it is frontal, parietal, and temporal lobes. We start seeing the temporal lobes and the glomus of the choroid plexus within the ventricle, head of the caudate nucleus, thalamus, and this is the caudothalamic groove, head of the caudate and the thalamus. This area is important because this is where the germinal matrix is located. Finally, this is the last area that the germinal matrix exists here, head of the caudate, thalamus, and that's the groove. There is a cyst here. We don't see the germinal matrix. Germinal matrix is a factory of neurons in the brain in the fetal life, and it's aligned along the lateral ventricles. It is formed of, it's a gelatinous structure formed of capillaries without structural support, which means that it is highly vulnerable to blood pressure changes. And in the preterm infants, there is no autoregulation of the blood pressure. So if there is any change, it will be translated into brain and to the germinal matrix, and it will bleed. That's the consequence. This evolutes around 32 weeks of age, and it's larger. But after 32 weeks, we don't have it most of the time, and we don't see germinal matrix hemorrhage. That's why it's more common in the preterm infants. And this is the temporal lobe, frontal lobe, parietal lobe, MRI correlation, and some more images for transtemporal approach. As you can see, that's the axial image. That's the axial images of the brain on the MRI. Frontal horns of the lateral ventricles, occipital horns, third ventricle, and that's the basal ganglia, and that's the Sylvian fissure, and that's the brainstem, mesencephalon, as that's the correlation, the MRI. Just an example of a clot within the aqueduct of Sylvius here, between the third and fourth ventricle. That's the echogenic clot, and you can easily see it with transtemporal approach. Posterior fontanelle, we rarely use it. It's very tiny. It closes around 6 months of age, and you can better see the occipital horns and also the choroid plexus and cerebellum, and sometimes you can use it to see the hemorrhage within the occipital horns, because the hemorrhage layers within the occipital horns. And also you can assess the circle of Willis if you use Doppler. That's the coronal view of the circle of Willis. That's the axial view. It's easy, simple. I got these images 15 years ago, so the equipment are much better nowadays, so you can get very nice images, Doppler images. This is also the same. If you use a very sensitive Doppler setting, you can see the lenticulostriate vessels. They are the end arteries arising from the MCAs. So in the basal ganglia and thalami, the coronal and sagittal view corresponding to this. That's normal anatomy. And you can also assess the veins. For example, here the transverse sinus, we call the veins in the brain sinus, as you know. So transverse sinus and straight sinus, vein of the Rosenthal, basal vein of the Rosenthal here, and axial, by using different approaches. So ultrasound allows assessment of the normal anatomy nicely. And now I will show you some normal variants. I will start with the choroid plexus. Choroid plexus is echogenic. It lies within the lateral ventricles, extends into the third, fourth ventricle, and hemorrhage also appears echogenic. And hemorrhage is around the choroid plexus. So it may be difficult to differentiate choroid plexus and hemorrhage. So this is the normal appearance. This is the caudothalamic groove. That's the head of the caudate, and that's the thalamus. And the choroid plexus indents into the groove, but not as much as you can see here. That's the normal extension. And that's not hemorrhage, because we did an MRI for the same patient and we proved that there is no hemorrhage. So that's the normal extension of the choroid plexus and normal appearance. And also choroid plexus can be very prominent in the glomus, which is at the atrium of the lateral ventricle. You can have a double layer at this range. It's called a hump. So choroid plexus hump can be, so this is not hemorrhage over the choroid plexus. This is just the normal appearance. And you can do, if you get cine clips, you can see the difference between hemorrhage and choroid plexus. This is choroid plexus, echogenic, swiping, there is going to be hemorrhage too. So this is hemorrhage. That's choroid plexus. This is hemorrhage. So same echogenicity, but you can So you can use Yikilmaz. I will give you some more examples. And another normal appearance is punctate echogenicities in the brain. I see sometimes commonly overcalled. We got the Canon I800 and we started calling everything calcification afterwards. And this is our older ultrasound unit. Well, this patient I scanned with the old one too. So these echogenicities disappeared. Even the sonographers call this echogenicities calcifications, as you can see here. It really depends on the settings. Usually we never see this extensive calcification, even in infections. It's not like that. So it's just the settings. Cerebellum, we can see it. The vermis appears echogenic normally. It doesn't mean that it's abnormal. And this is the same patient with the MRI. There is no hemorrhage. This is a normal cerebellum from the mid-sagittal view, and with the mastoid fontanelle, you can see better on the mastoid view. Here appears echogenic. Also, the anterior aspect of the brainstem appears more echogenic. For example, here, that's the MRI correlation, mid-sagittal cerebellum, brainstem. So the dorsal aspect of the brainstem, tegmentum, appears hypoechoic, and the anterior aspect appears hyperechoic. And that's a normal view. It's most likely related to myelination because anterior aspect myelinates first. The problem is when you scan in the coronal view, you cut the pons and you can see the anterior aspect of the brainstem, and you may think that this is hemorrhage because hemorrhage is also hyperechoic. Every abnormality is hyperechoic in the brain. It's not like ultrasound. And you may think that this is some hemorrhage within the fourth ventricle, or it may confuse you, but you're just cutting the anterior aspect of the brainstem. Most of the time it's pons. Pons is bulky, and you're seeing pons as an echogenic structure. Immature white matter. In the preterm infants, we can see the white matter like this, very prominent around the ventricles and here. And you can see the perivascular spaces as linear echogenicities. You can see here. In the preterm infant, it's completely normal. You shouldn't overcall it. It's called, some people call it flare, like white matter flare. It is corresponding to this perivascular spaces that you can see on the MRI, and we are just seeing them on the ultrasound. Also, the gyral pattern may be simplified normally in a preterm infant because the brain is not formed yet, well formed. And in the term infant, that's the gyration. So it is more developed in the term and less developed in the preterm. So that's normal as a preterm. But if you see the simplified pattern in a term infant, just like this case, then it is abnormal. So in this patient, the patient had lissencephaly, Miller-Dicker syndrome, and it was 38 weaker, so it was abnormal. Another one is lenticulostrate vasculopathy, also known as mineralizing vasculopathy, but there is no calcification histopathologically. So this is the echogenic linear and branching structures within the basal ganglia and thalami, as you can see on the coronal and sagittal views. So these are actually corresponding to the reflections from the wall of the lenticulostrate vessels. They are most of the time normal structures, but this corresponding to these lenticulostrate vessels. Most likely because of some settings, we are seeing the reflections from the wall. They're just normal variants. But like they started doing some research. They showed some association with HIE and CMV with this, and it was reported to be abnormal. But there is new research showed that some examples. This is just an association, not a correlation, and that's our observation too. We do this. We commonly see it in the especially in the preterm infants, and as an isolated finding. And the patients are fine. Even if you do further investigation, you find nothing. So you should, if this is an isolated finding, you should know that this is a normal variant, not an abnormality. These patients should not be further investigated. Another ultrasound finding is cortex white matter differentiation that I want to mention. Here is the normal cortex white matter differentiation. The cortex is slightly hypoechoic, darker, and the white matter is slightly hyperechoic. That's the normal. So in some cases, you may see decreased cortex white matter differentiation. For example, this case. And this is abnormal. Cortex is involved, white matter is involved. Sometimes white matter is involved and cortex is spared, so you have accentuated cortex white matter differentiation. This is also abnormal. So everyone knows this, decreased differentiation, but you should also know that accentuated cortex white matter differentiation is also abnormal. And when we are scanning, sometimes we see this echogenic structure in the midline, paramidline position, and we may think that this is hemorrhage or choroid plexus, but it's actually the internal cerebral vein. If there's a pair of internal cerebral veins here, and that's the structure. And if you do Doppler, you can see vascularity in it. And that's just a normal structure, not hemorrhage. We commonly see slit-like ventricles. Slit-like is like we used only for the lateral ventricles, and the ventricles look collapsed. So it is common, especially in the term infant, especially within the first few days of life. Most likely the brain is squished during vaginal delivery and it causes some collapse of the ventricles. We don't know, but usually it goes away after a few days and there is no clinical significance. But sometimes there is brain edema, occasionally. So how do you differentiate brain edema, brain swelling from slit-like ventricles? So in this case, you need to look at the interhemispheric fissure. So here, interhemispheric fissure and the pericerebral CSF spaces are also effaced. And this is brain edema. But if you see the interhemispheric fissure open and the pericerebral CSF space is open, this is just normal. So this is how you differentiate it. Just look at the interhemispheric fissure. In all normal cases, you should be able to see the interhemispheric fissure. How is the image quality? Should I turn off the lights completely? Good. Okay. Okay. Cavum septum pellucidum. This is also sometimes very confusing. So every child has cavum septum pellucidum in fetal life, and 85% of terms and 100% of preterms has a cavum. Cavum is this structure between the frontal horns of the lateral ventricles here on the MRI, on the ultrasound. It is an indicator that the midline structures are well formed and everything else is fine. So the obstetricians are obsessed with this cavum because if they don't see this cavum, they think that, okay, there may be some other midline anomalies. So when they see this, or they feel good, okay, there is no other midline anomaly that I'm not seeing. So that's why. But after birth, they don't mean anything. They usually disappear after 6 months. I mean, these two membranes merge, so they form the septum pellucidum. It's just a normal structure. It is not connected to the ventricles. So the pathologies like hemorrhage within the ventricle does not extend into this. Here, this is the absent cavum septum pellucidum on the ultrasound. So there is no cavum, there is no septum at all on the MRI. In this group of patients, they need to be further investigated for septoptic dysplasia, for other syndromes. Corpus callosum may be abnormal too. Pituitary gland may be abnormal. This is abnormal. Sometimes the foramen Monro is prominent. For example, here, the lateral ventricle and the third ventricle here. The foramen Monro is prominent even on the MRI. So this and partially absent septum pellucidum does need to be further investigated? No. And this is just a normal variant. So there are other cavums too. We have the cavum varga, which is septum pellucidum is anteriorly located. Varga is posteriorly located. And we have cavum veli interpositi, which is posterior and inferiorly located here. They are all normal variants. And here is the posteriorly located varga. And here is the typical appearance of the cavum veli interpositi. This coronal triangle shape appearance is typical. They don't have any clinical significance. Once a while, we see them dilated, forming cysts in the older children. Very rarely, they need to be intervened by surgery, but otherwise, this is just normal structure. This is not a cyst. You don't have to do an MRI. You don't need to do a follow-up for this. But sometimes we see some structures within the cavum septum pellucidum or varga here. You can see. So this is not third ventricle, right? This is third ventricle somewhere down. This is the cavum. So within the cavum, there are these linear lines. Is this debris? Is this infection? Ventriculitis? Hemorrhage? No, these are septal veins. The septal veins course along the septum, but when there's cavum, sometimes they traverse through the cavum, and we can see them. And because the cavum is not communicated with the ventricles, you don't get an infection within the cavum anyway. So these are just septal veins, and they don't have any clinical significance. And we commonly see tiny, simple subdural collections, as you can see here on the ultrasound. Tiny. This is the subarachnoid space. This is a coronal view by using a linear probe, high resolution. So here's the brain. Over the brain, there is the subarachnoid space, which is slightly echogenic, which is normal. And we have these anechoic, simple subdural collections, particularly around the dura, around the falx here. And this is the superior sagittal sinus. And these are, if you do an MRI, you can barely see them. They are 1 to 3 millimeters usually. Or if you don't do a high resolution MRI study, you don't see them. They fluctuate in size. They don't show mass effect on the brain parenchyma, just a little bit on the subarachnoid space. If you repeat the ultrasound in the afternoon, they may go away. If you repeat the next day, they can come back on the other side. They fluctuate. We see them up to 1 year, 2 years, not only in the newborn. Here, another example. tiny. These are commonly overcalled as subdural collections. And then, is this non-accidental injury? Is this some kind of trauma? What shall we do? If you do a follow-up, your reports will be inconsistent. You won't be seeing them, or it will increase in size. So most likely they are lymphatic collections. Most likely they are physiologic. So there's arachnoid correlations and meningolymphatic vessels around the dura. This is an MRI study showing the lymph drainage in the brain. These blue ones are the lymphatic fluid in the brain, and that's the dura. And most likely we are seeing them on the ultrasound here, but it's not reported in the literature yet. No one knows. Sometimes we see some collections within the subarachnoid space as well. That's brain. Subarachnoid space, normally some echogenic. That's completely normal. It doesn't mean that it's abnormal. And we see these anechoic collections. I think it's just chyle, physiologic. And sometimes they accumulate and they form these cysts. I think it's the same idea. I think they are just clumped together and we just see them. Most of the time, these children are very healthy. It's not pathologic, but this is a confusing finding and easily overcalled. Also, we have the congenital cysts. Congenital cysts are typically located along the frontal horns and anterior body of the lateral ventricles, bilateral. You may think that there is a septation between the lateral ventricle, as you can see here. They are considered to be a part of the embryologic process. So it's nothing. They just disappear after a few months and not pathologic. They are outside of the lateral ventricle within the brain parenchyma. Another example, congenital cysts. And then sagittal, we did MRI. On the MRI, we can see the cysts along the ventricles. And around 7-week-old, they disappeared. I think they just merge with the ventricle or they just disappear. So these are most common intracranial cysts based on the location, based on the prior imaging, if you compare with the prior, or based on the prematurity of the patient, you can easily differentiate between these cysts. I told you about congenital cysts. Germinal matrix hemorrhage usually resolves without leaving a cyst, but sometimes they leave a cyst. So if you know the child is premature, had hemorrhage, and the cyst is located within the caudothalamic groove, you know that this is secondary to germinal matrix hemorrhage. CMV may present with periventricular cysts along the ventricles, bilateral symmetric. Sometimes there are arachnoid cysts. They may be associated with agenesis of corpus callosum in different locations. They are extraaxial cysts. White matter injury of prematurity, also known as PVL, is multiseptated cysts, periventricular and posteriorly predominant. There is also germinolithic cyst, which is originated from the germinal matrix, just like hemorrhage, but it's not hemorrhagic. It's septated. It's a complex-looking cyst, and most of the time benign. It may be associated with CMV, but most of the time they just disappear without any problems. You can differentiate it from the others because they appear complex and they can appear also in term infants, unlike germinal matrix hemorrhage. So if you see a complex cyst in a term infant and the patient is doing fine, you should consider this. Porencephalic cysts are periventricular cysts. They are secondary to periventricular hemorrhagic infarction. So you know that there was a prior hemorrhagic infarction and they merge with the ventricle and they leave this cyst. It's called porencephalic cyst. And choroid plexus cysts you can see within the choroid plexus, and they can be anywhere along the choroid plexus. They don't have any clinical significance. In the prenatal life, if you have multiple choroid plexus cysts, it may indicate trisomy 18, but trisomy 18 is a very severe syndrome associated with facial anomalies, cardiac anomalies. The choroid plexus cysts will never be the only finding. So, but after the baby is born, the choroid plexus cysts have no clinical significance. You don't even need to report them. They're just tiny cysts. They just disappear. They don't have any clinical significance. So I tried to summarize the cysts here. So green is no clinical significance, yellow is usually benign, red is poor prognosis. And based on the location and based on some clinical findings, you can easily decide the origin of the cyst. And also the cavum anomalies, cavum variants are usually overcalled as cysts, by the way.
Dr. Yikilmaz.
Yeah.
Just a quick question. Is there a difference between a conatal cyst and a choanal cyst?
Choanal.
Yeah.
I never heard choanal. I heard frontal horn cyst.
Yeah, I think. Okay, so if it's anterior to the frontalmost part of the frontal horn, it's a frontal horn cyst.
Yeah.
Or choanal cyst.
Yeah, conatal. I never heard choanal.
Okay.
Choanal. Yeah, maybe frontal horn cyst, and also germinal-lytic cysts are called pseudo-subependymal cysts. Germinal-lytic cysts. I can share the slides with you. You don't need to take notes. Yeah, I always do, so I forgot to tell you. So. Okay, any questions regarding the cysts? So, okay, good. So that's the end of the first session. So we discussed the technique, the sonographic anatomy, and normal variants, and some cysts, how to differentiate the cysts. And we will give a break, and after the break, we will continue with intracranial hemorrhage. And we can discuss in the break if you have any questions.
I don't know, like, I was about to start with just the journal. Long time to see.
I know. I missed you.
You guys just heard? All the rest look like it's a good album at the same time. I believe it. Very festival.
The visuals are
Like, I like the right sound, yeah. Like, maybe one. Because I think like,
I wouldn't do it this year, so I already I don't know.
I really like yeah, like around. I had a case like
I don't think there's anything going on with
Shall we start? Okay. So the second part of the lecture will be on hemorrhage. And this is a table based on the etiology. I wanted to summarize all the injuries in the perinatal brain. So they can be thromboembolic, hypoxic ischemic. They can be related to prematurity, trauma, or coagulopathy. Coagulopathy is involved in all of them. But so this is very gross classification. I just wanted to follow this for my lecture. So I will go through them one by one. So this is mainly covering all the brain injuries in the newborn. So the first one will be, before I start, we need to learn that there's a saying in pediatrics that children are not small adults. And in the neonatology, there is a saying that preterm neonates are not just small neonates. Because their anatomy is different, their physiology is different, the diseases we see in them are different. So this is like a preterm, this is a term baby. As you can see, they are not the same. For example, typically we see germinal matrix hemorrhage, periventricular hemorrhagic infarction, PVL, or white matter injury of prematurity in the preterm infants, particularly in them, because of many things. We will discuss on them shortly. And I will start with the first one, arterial infarction and infarction secondary to venous occlusion, most likely the thromboembolic etiology. So here is an example of a localized infarction. So all the pathologies in the brain appear hyperechoic, right? So infarction is also like that. you can see a small infarction in the brain. It's just an echogenic focus. Is this hemorrhage? Could be. Is this infarction? Yes. Not very non-specific. But it can also involve large arteries. We can also see MCA infarction, and that this is an example. So the baseline, the child was doing fine, had cardiac issues, but doing fine. Then the clinically deteriorated, and we repeated the ultrasound, and on the ultrasound we see loss of gray white matter differentiation here, swelling of the brain. That's the normal right side, that's the abnormal left side with the linear probe with the higher resolution. And that's on the parasagittal view, normal right side and abnormal left side. You can see the difference. White matter is bright and there is decreased cortex white matter differentiation. And this is the MRI CT correlation after 3 months. And this is there is chronic infarction of the MCA territory. Usually it's not as sensitive as MRI. It takes some time, at least a week, to see the changes nicely on the ultrasound. Here is another example of an arterial MCA infarction. Initial ultrasound, we see some changes, loss of cortex white matter differentiation on the extended parasagittal view, and it becomes more prominent at 2-week follow-up. And this is the CT correlation. As you can see, there's infarction in the MCA territory, but there's also hemorrhage. And on the ultrasound, you can't really differentiate between hemorrhage and the infarction. And in this patient on the CT, you can see this is a non-contrast CT study. You can see the clot within the supersagittal sinus and internal cerebral veins, vein of Galen, and there is some hemorrhagic infarction in the left cerebral hemisphere. On the ultrasound, you can see the infarction. Typically, the cortex is preserved in these kind of large sinus infarctions, large venous infarctions, and white matter is involved. And this is the MRI follow-up of the patient. You can see the loss of white matter with preserved cortex over it. So this is the thromboembolic etiology. After this, hypoxic ischemic injury and parenchymal hypoxic ischemic injury, parenchymal hemorrhage will be later. So hypoxic ischemic injury, normally we don't see much in hypoxic ischemic injury, and on the ultrasound, it's usually by MRI. On the ultrasound, the findings we can see can be diffuse edema. This is usually the initial finding. You can see some brain swelling, loss of cortex white matter differentiation, effacement of the ventricles or pericerebral spaces, and this is the MRI correlation, diffuse edema. And in HIE, there are 2 patterns, right? Central pattern and peripheral pattern. Central pattern, we see infarction in the deep structures, as you can see here in the lobus pallidus and thalami, and this is when there is severe asphyxia. And on the ultrasound, we can detect them. And when there is mild moderate asphyxia or hypotension, we see peripheral pattern. In the peripheral pattern, MRI usually shows the findings. We sometimes see some edema, or very rarely we see parenchymal changes, but the findings on the ultrasound is usually delayed, and we usually don't see much on the ultrasound. So when you see basal ganglia, thalami involvement, especially in the term infant, you should consider central hypoxic ischemic injury, and this is usually poor prognosis because there is severe asphyxia. That's how the ultrasound helps. Usually ultrasound in HIE is helpful to exclude other pathologies. Okay, so then we come to prematurity-related pathologies. Germinal matrix hemorrhage, periventricular hemorrhagic infarction, and cerebellar hemorrhage. So these usually happen just because the baby is a preterm, just because born early. But the other factors like HIE, coagulopathy, other factors also contribute. But you don't need anything else. If the baby is born preterm, you can have germinal matrix hemorrhage, you can have hemorrhagic infarction or cerebellar hemorrhage. So why is ultrasound screening important? Why are we doing these ultrasounds? So it is routine in all preterm infants under 32 weeks. Why are we doing this? So usually there is no treatment for hemorrhage. We are not treating hemorrhage. So it's happening. We are just observing. There is no treatment for PVL, white matter injury. So why are we doing screening? And what happens is, we have these are the two most common pathologies: germinal matrix hemorrhage, white matter injury. And germinal matrix hemorrhage causes intraventricular hemorrhage, may cause intraventricular hemorrhage, not all the time. Then it may cause obstructive hydrocephalus, and obstructive hydrocephalus can cause neuronal loss. That's why it's important. And white matter injury causes neuronal loss. And neuronal loss means there's function of those neurons. There's loss of function of those neurons. So that's why it's important. So we cannot avoid this. We are doing the ultrasounds for prognostication, but for the hemorrhage, we can actually treat the obstructive hydrocephalus. We can manage obstructive hydrocephalus, and we can prevent this neuronal loss. If you manage well, you can prevent, but you cannot prevent hemorrhage. You cannot drain hemorrhage. So that's why an ultrasound is recommended in all preterm infants under 32 weeks of gestational age, as per Canadian Pediatric Society screening recommendations. Over 37 weeks, it's not their term. Over 37 is term, and not routinely recommended. And if there's a suspicion for a congenital anomaly or others, and you can still do it, but otherwise ultrasound is not recommended. Between 32 and 37, it's not routine, but if there are additional risk factors, you can do an ultrasound. Under 32, it's always recommended. And the timelines change, but here the most basic one is this one. In Canada, we scan less frequently. In Europe, they scan more frequently, but this is really basic. What we do is 2 ultrasounds, basically. First ultrasound is between 4 to 7 days, and the second ultrasound is between 4 to 6 weeks. And in the extreme preterm infants under 26 weeks, you add a term-corrected age third ultrasound. So this is at least 2 ultrasounds if everything is normal. If there's hemorrhage or other abnormalities, then you need to add some more ultrasounds in between. So you may end up having serial ultrasound studies if there is some abnormality. But if there is no abnormality, if the first ultrasound is normal or just showing grade 1 germinal matrix hemorrhage, you don't need to do anything else. Just wait for the second ultrasound, which is between 4 to 6 weeks. Okay. So how do we see the germinal matrix hemorrhage? Why are we doing the first ultrasound between 4 to 7 days? Why do we wait for 3 days to do the first ultrasound? Because 90% of the germinal matrix hemorrhages occur within the first 3 days of life. So if we are doing the first ultrasound on the 4th day, so we catch them. If you do the ultrasound on the first day, then the second day there may be hemorrhage and you may miss it. That's why we wait for 4 days, but it doesn't hurt to do the first ultrasound if there is a clinical suspicion of hemorrhage. So we do the ultrasound and we can see the hemorrhage. We don't see the germinal matrix on the ultrasound, and we just see the hemorrhage within the carbothalamic groove because this is where the germinal matrix is located until 32 weeks of gestational age. there is the ependyma over it, ependymal surface. And when it's under the ependyma within the caudothalamic groove, we see it's like a grade 1 hemorrhage. Then when there is rupture, it ruptures into the ventricle, it ruptures the ependymal surface, and it becomes intraventricular. Subependymal, intraventricular. And usually the hemorrhage goes anterior, posterior, along the choroid plexus and to the dependent aspects of the ventricle within the occipital horns. And here you can see a cyst caused by this hemorrhage. This is the germinal matrix hemorrhage, very typical. And after 6 weeks, we can see a cyst, residual cyst. Germinal matrix, they showed this germinal matrix by using specimens. So this yellow structure is germinal matrix. It's the factory of neurons. All the neurons are produced here and migrates peripherally. And as you can see here, initially they are it's not very large, so it becomes larger than involutes. And we don't, this is around 21 weeks. We can see them along the lateral ventricle here, 21. We can see them until 32 weeks. On the MRI, if you do a fetal MRI, you can see the germinal matrix like a hypoechoic structure. So hemorrhage will be occurring from this structure. And recently, this paper published hemorrhages here. That's the anterior hemorrhage within the caudothalamic groove. They also published that in extreme preterm infants, you can have hemorrhage not only within the caudothalamic groove, but also along the course of the germinal matrix, which is more posterior. As if you pay attention to this, in 21 weeker, there is a germinal matrix even in the posterior aspect. So you can have a hemorrhage from there too. So in extreme preterm infants, you can have a posteriorly located subependymal germinal matrix hemorrhage too. So they made this discrimination anterior and posterior germinal matrix hemorrhage, which is sometimes problem solving. So this is a typical germinal matrix hemorrhage, anteriorly located, 27. But in a 25 weeker, you can also have a posteriorly located germinal matrix hemorrhage because there's still some germinal matrix posteriorly along the lateral ventricle. And
sorry, how would you differentiate that from like the pump variant germinal matrix? Is it just more heterogeneous?
oh, this is more at the anterior is at the caudothalamic groove, and this is more posteriorly extensive. This is the groove, and this is more extending posteriorly by location. This still can be subependymal. This doesn't have to be intraventricular, although it looks like intraventricular. So in this paper, they claim that even if this looks very posterior and large, it can still be grade 1. This is completely a different approach than the classification system we know. But this is a new study. I just wanted to mention this. So this is the normal caudothalamic groove. That's the normal appearance. That's the choroid plexus extending into the caudothalamic groove. That's the thalamus. That's the head of the caudate. That's normal. On the coronal, we can see them as echogenic structures, not very extensive into the ventricle, slightly extensive. And this is the proof that it's not hemorrhage. We did an MRI, there is no hemorrhage. But when there is hemorrhage, it is more prominent, more extensive into the lateral ventricle. It can be unilateral or bilateral. So here on the right side, it is larger compared to left. And on the sagittal, we can see it more extensive into anteriorly. So this is a germinal matrix hemorrhage, grade 1 on the right side. Sometimes we see a very tiny focus on the left. We don't know if it's hemorrhage or not. If you do an MRI, even on the MRI, it's hard to see them. we only see them on the SWI, as you can see here. On the T1, T2, we don't see it, but only on the SWI we can confirm this hemorrhage. So sometimes small hemorrhages can be better seen on the ultrasound. Here is another example. The left choroid plexus appears larger than the right, more bulky, more heterogeneous, more hypoechoic compared to right side. So right side is normal. Left side, there is hemorrhage. This hemorrhage is extending from the germinal matrix, caudothalamic groove, and extending into the ventricle along the choroid plexus. And this is the confirmation with MRI. These dark areas are hemorrhage. So there is the choroid plexus under it and hemorrhage over it. Here, the choroid plexus can be slightly bulky. It can have a hump, but it's not never like this. This is very irregular, very heterogeneous. Some parts are very hypoechoic. And so this is actually hemorrhage, not a normal choroid plexus. And this is the confirmation with MRI. Most of the time, when we say there is no hemorrhage, if you do an MRI, usually you see some hemorrhage. So we are usually not seeing much on the ultrasound. We are undercalling most of the time. As you can see here, no, we should be calling more often these irregularities as hemorrhage. Another one, there is this echogenicity along the occipital horn of the lateral ventricle. And this choroid plexus? No, choroid plexus does not extend to the wall of the ventricle, lateral wall. As you can see here, this was actually hemorrhage on the MRI. And also some hemorrhage here too. The grading system was introduced 50 years ago, 50. And it was based on CT. So they were not using ultrasound at that time. So it is very simple. It doesn't really fit all the cases we see today, but we are still using them. Papille introduced it, and then Volpe actually improved it in a different way. So grade 1, grade 2, grade 3, they are the same in Papilla and Volpe. There is hemorrhage within the caudothalamic groove, does not extend into the ventricle. In Papilla, a little bit can extend into the ventricle, less than 10% of the lateral ventricle size. But they are still grade 1. In grade 2, there is hemorrhage in the ventricle, but there is no associated ventricular dilatation. In Volpe, the hemorrhage is between 10 to 50% of the lateral ventricle size. And in grade 3, there is associated ventricular dilatation. And in Volpe, there is over 50% of hemorrhage within the lateral ventricle. And in Papille, grade 4, there is a grade 4. They thought this was the extension of the hemorrhage into the parenchyma. But Volpe accurately said that, no, this is not extension of the hemorrhage. This is a completely different entity. We should call it periventricular hemorrhagic infarction, not germinal matrix hemorrhage, which is more accurate. So that's the difference. So in Volpe, there is no grade 4. There is periventricular hemorrhagic infarction instead of it. And grade 1 is more common, as 45%. And morbidity and mortality rates increased by grade, as you can see here. Broadly speaking, in grade 1, the prognosis is excellent. Usually there is no neurological sequelae. And in grade 4, there is usually some neurological deficit. This is how they appear on the ultrasound. In grade 1, we see small hemorrhage within the caudothalamic groove only. There is no extension of the hemorrhage into the ventricle according to Papille. Little bit of hemorrhage can extend according to Volpe into the ventricle, still grade 1. In grade 2, there is no ventricular dilatation, but there is hemorrhage within the ventricle. in grade 3, there is associated ventricular dilatation. And in grade 4, or periventricular hemorrhagic infarction, there is an infarction. The main pathology is an infarction of the brain parenchyma, but it's an hemorrhagic infarction and always extends into the ventricle. Example, 4-day-old, we are doing the first ultrasound. We confirm 2 grade 1 germinal matrix hemorrhage. You grade them separately, right side separately, left side separately. So on the right side, grade 1, on the left side, grade 1. And when you do the follow-up, you can see as other hematomas, they gradually become hypoechoic and sometimes cystic, and then they resolve completely. And usually the prognosis is excellent, as you can see here. The grade 4 or periventricular hemorrhagic infarction can be unilateral, bilateral, but most commonly in the parietal lobes, posteriorly, not at the caudothalamic groove. And initially, they are hyperechoic because it's an infarction. That infarction then evolves, become more hypoechoic. Then this infarcted brain is gone, leaving a cyst, which is called porencephalic cyst, and it always communicates with the lateral ventricle. And eventually, at the 90-day-old ultrasound, we can see a porencephalic cyst merge with the lateral ventricle here. So these neurons are gone. They are the main pathology here is obstruction of the subependymal veins. And there is rupture of the medullary veins. They can be small or very large, as in this case, and there's always hemorrhage. There's always hemorrhage extending into the ventricle. And here you can see a very large porencephalic cyst around 12 weeks old. So why is hemorrhage important? First, we are doing these ultrasounds for prognostication. For example, if grade 1, okay, good, we can tell the parents that there's some hemorrhage, but the prognosis will be good. If grade 4, we can tell them there will be some neurological deficit. But as I told you before, if you manage the hemorrhage well, you can avoid the ventricular dilatation or hydrocephalus, and you can avoid further neuronal loss by hydrocephalus. So how do we do that? We have some tools to manage the hydrocephalus. For example, in this case, after the hemorrhage, there is a post-ventricular dilatation occurs, and you can see on the 20th day, the neurosurgery inserted a catheter. So we have some diversion options. So this is serial lumbar puncture because there's lots of CSF. The pediatricians do serial LPs once a day, 10 cc tapping, and they repeat this three days. Consecutively 3 days, they aspirate 10 cc CSF by doing a lumbar puncture. This is usually the initial response when there is dilatation. Then these are the other options: external ventricular drainage, ventricular access device, ventricular subgaleal shunt, ventricular peritoneal shunt. The problem is if you insert a shunt, then it will stay there. This is a newborn baby. The baby will grow, and you need to revise the catheter. The catheter will be short. Or you will cause an infection. An infection will be devastating for a newborn. So you don't want to insert a VP shunt if it is not really necessary. But at the same time, you want to avoid the complications of hydrocephalus. So how do we decide that? Based on some factors, but primarily based on ultrasound and primarily based on our measurements. So these measurements are of the top priority when doing an ultrasound. If there's a germinal matrix hemorrhage, it's not really important to grade the grading of the hemorrhage. Most likely you won't be accurate unless you do an MRI, but it is important to measure them nicely so that the surgeons will decide if they should insert a VP shunt or not. So for this purpose, there are some measurement techniques. So whatever you do, there are many options. Whatever you do, you should always use the same measurement so that you can do an appropriate follow-up. Here we use anterior horn width, so HAHW. So that's very accurate, very reproducible. And there's also ventricular axis if you measure the frontal horn like this. There is also called this measurement between the midline and the lateral aspect of the lateral ventricle is called ventricular index. It's just a measurement. And you can also measure the hemispheric width. That's the most lateral aspect of the cerebral hemisphere and the midline. And you can have this frontal horn ratio if you ventricular index divided to the hemispheric width, and it's normally under 33%. We don't use it. We use the anterior horn width. Normally it is under 3 millimeters. If it is over 6 millimeters, it requires intervention. You can also measure the ventricular height, or you can measure the thalamo-occipital distance. These are all reproducible or all accurate. For example, thalamo-occipital distance is normally under 16 millimeter and requires intervention over 25 millimeter. But these measurements are not easy. There is no consensus. For example, here, where do you measure the ventricle? From here, when there is hemorrhage, or from here? So I think we need to measure the ventricle even though there is hemorrhage, but there is no consensus and there may be some discrepancy between the measurements. So this is a paper that our NICU team is using. So this is like an algorithm how to approach these children. So based on our ultrasound measurements and their clinical assessment, head circumference assessments, they group these newborns into 3 as green zone, yellow zone, and red zone. If the baby falls into green zone, the management is observation in NICU and cranial ultrasound a week until stable, then MRI at term equivalent. They recommend an MRI no matter what. And in this group, the measurements, anterior horn width measurements are under 6 millimeters, 6 or under. In the yellow zone, anterior horn width measurements are over 6 millimeters, under 10 millimeters. And in this group, the management is LP. So they do LP 2 to 3 times, which means 2 to 3 days, and then neurosurgical intervention. And if the patient falls into red zone, this means that anterior horn width is over 10 millimeters, and then you consider LP 2 to 3 times, and neurosurgical intervention, including VP shunt, is on the table. So that's why these measurements are important. So these are the normal ventricular index, anterior horn width, thalamo-occipital distance values. For example, for the anterior horn width, 3 is normal, yellow zone. 6 is the first threshold, and 10 is the second for high risk. Over 10 is very high risk. High risk, so neurosurgery should consider intervening. So that's why the hemorrhages are important. Do you have any questions? So that was it for the hemorrhage. Yeah, sure.
For the LPs, like, is the hydrocephalus, is it like a communicating hydrocephalus thing, or is it like non-communicating? Like, why does the LP tell us?
Yeah, so communicating is between the fourth ventricle and the subarachnoid space. If it is communicating, it's communicating. Usually it is non-communicating because the clot, like aqueduct of Sylvius is very thin, right? Usually it can be easily obstructed with a 1 millimeter clot. And usually it is around that. It doesn't really matter unless the lateral ventricles are, the lateral ventricles are dilated, then it doesn't matter where it is obstructed. It's usually obstructive hydrocephalus. And then you remove some of the CSF from the spine, but you drop the pressure. Because when the lateral ventricles are dilated, they will compress on the brain parenchyma and they will cause neuronal loss. Most of the time, it's irreversible. So that's why they want to avoid that. But at the same time, they don't want to rush doing that because when you do that, the patient will be dependent on the shunt and then there may be infectious complications. So it's a hard decision. You will always see this fight between neurosurgery and neonatologist. Neonatologist asks them, hey, why don't you do a shunt because the baby has postventricular hemorrhagic dilatation? And the surgeon says, oh, it's too early. Let's wait a little bit, make sure that it's not resolving by itself. Then the neonatologist will be, okay, let's do another ultrasound then. So they do a follow-up every day and we report that there's no change. So in your report, you should be saying in your reports, the grading is done based on the first ultrasound. For example, we do the ultrasound on the 4th day of life, and we say, okay, grade 3 germinal matrix hemorrhage. So the morbidity will be according to grade 3. So let's say you repeated the ultrasound the next week, and you saw some improvement. So the ventricular dilatation improved, so it became grade 2. It doesn't mean that you will change your morbidity or prognostication. Or if it becomes grade 4, you won't change your grading. It's based on the first ultrasound. So on the follow-up ultrasounds, it doesn't make much sense to regrade. You just say there is hemorrhage in the ventricle, that's what matters, because if there's hemorrhage in the ventricle, it means that it may obstruct, it may cause hydrocephalus. So they will continue following up. If you say that there is no hemorrhage in the ventricle, they're relaxed. They don't have to do repeat ultrasounds and follow-ups.
So if there was a grade 1, but it worsened,
Yeah.
then you just say significant worsening.
Yeah,
Say
I mean,
1 to
yeah,
grade 4,
yeah.
say significant worsening.
So initially there was no hemorrhage within the ventricle. It was subependymal. Then now I see intraventricular hemorrhage. So they need to follow up. There is intraventricular hemorrhage because you may have post-hemorrhagic ventricular dilatation now, and you may have some neuronal loss. And you make the measurements basically. So when I report as a follow-up study, I usually look at the first study. Okay, there is intraventricular hemorrhage, dilatation. I just do the measurements. I try to make the measurements accurate. That's what matters. I usually remeasure. And a few millimeter differences does not affect much. How often do we recommend MRI? I mean, based on this, when the baby reaches the term equivalent, for example, baby is born 28 weeker. So you wait for 12 weeks, the baby reaches to 40 weeks, then so around 3 months, you do an MRI. MRI is done for prognostication. So it gives an idea for the future. It doesn't help for the management.
So like, let's say after the initial ultrasound,
No, we never recommend that. We never recommend unless we have a questionable diagnosis. So if you're sure that it's a germinal matrix hemorrhage, you don't need an MRI immediately. And most of the time, the children are not stable to do an MRI. So you wait until the baby is 40 weeks old, then you do the MRI after the baby is stabilized, but then you're going to do it under sedation. In HIE, we do MRIs, not for the hemorrhage. If there's HIE, it's also for prognostication. It won't change the management. For HIE, the only management is cooling the brain. And MRI, we do the MRI just for the discussion with the parents. And it's not always accurate. Right. So the next topic will be hemorrhage, parenchymal hemorrhage. Most of the time related to trauma and also coagulopathy is contributing to this. And here, these are all different patients, 6 different patients. And do you think these are parenchymal hemorrhages? So this group, and this group, they are all different. Which one is hemorrhage? Can you tell? It's not possible to tell, honestly. They are all echogenic. And in this group, these are two, this is basal ganglia infarction in the temporal lobe, hematoma in the brain parenchyma, hematoma in the posterior temporal lobe, and this is a tumor. So they all appear echogenic. Hematomas appear a little bit more echogenic and more well-defined, but it's not possible to differentiate. Maybe you can do a Doppler here. You can tell if there's vascularity in it. But based on these sonographic appearances, you can't tell. Some examples, you can have a subcortical hemorrhage in HIE. You can have a deep, large hematoma in the basal ganglia in patients with alloimmune thrombocytopenia. And this patient had hemorrhage, subcortical white matter hemorrhage, due to hypertension secondary to coarctation of the aorta. They all appear as echogenic lesions. Another one, like diffuse hemorrhage within the brain parenchyma on the ultrasound, and this is correlation with the MRI. Hemorrhage can be intrauterine, and when the baby is born, it already evoluted. We see a cyst. It's called a porencephalic cyst because it's secondary to an underlying pathology. And here, if you do the MRI on the first day of life, we see some cystic changes and some hemorrhage. So, and the subpial hemorrhage is a new terminology. We didn't know it maybe 10 years ago, but it's very common. Nowadays, we report all these intraparenchymal hemorrhages as subpial hemorrhage. So subpial, it's controversial term because there is pia matter over the brain, and we imply that this hemorrhage is under the pia matter. So, and there's always a component of venous infarction, venous component. So it is like subarachnoid hemorrhage, but it's not free. It's under the pia. It's still confined to brain surface, but it's not subarachnoid. It's not subdural. It is subpial. And this is an example. They are peripheral hemorrhages. They appear echogenic and MRI correlation. And we published this last year in RSNA. They may present with as a gyriform hyperechoic lesion, as you can see here. In the past, we used to call them subarachnoid, but it's actually confined hemorrhage. Sometimes the other presentation is the sonographic yin-yang appearance, as here. The periphery of the lesion is hyperechoic. Central part of the hematoma is hypoechoic, always peripheral. And we sometimes see a hyperechoic mass with lobulated margins. and also a fan-shaped hyperechoic lesion. These are the 4 presentation types of subpale hemorrhage in the newborn. Most commonly secondary to birth trauma, vacuum, suction, but also there's a coagulopathy is contributing to this, and sometimes prematurity is contributing to this. Other examples here, that's the ultrasound, that's the MRI correlation. That's the ultrasound here and here, that's the MRI correlation. As you can see, it looks like is it in the brain or outside of the brain? When you're thinking of it, you should know that it's subpale hemorrhage. Also here, it looks like a subarachnoid hemorrhage, but it's confined. It's not free. This is the hemorrhage. All right. The other hemorrhage type is cerebellar hemorrhage. This is also a new thing. We didn't know that we could have hemorrhage within the cerebellum, but cerebellum also has its own germinal matrix, and it's also prone to bleeding. So we see hemorrhages. It is 2.5% as an isolated finding, but when there is associated germinal matrix hemorrhage, it may increase up to 19% under 32 weeks. So it is fairly common, and it has a negative impact on prognosis. So if you mention this in your reports, it will help for the prognostication. As you can see here, most of the time we do ultrasound, we don't see anything. When you do the MRI, you can see foci of hemorrhage within the cerebellum. If the hemorrhage is greater than 4 millimeter, they are visible on ultrasound, as you can see here, and that's the hemorrhage on the MRI. That's how we see it on the ultrasound. It's a fairly new entity, so most of the time the sonographers don't expect to see hemorrhage in the cerebellum, so they quickly scan the cerebellum, but if you do a careful scan, you can see these tiny hemorrhages in the cerebellum. In this one, the patient was doing fine, normal ultrasound, and clinical deterioration. We repeated the ultrasound study. We saw this huge hemorrhage within the cerebellum on the coronal view and on the fontanelle view. Very large hemorrhage. And this is another hemorrhage confirmed with the CT. On the CT, we see this cerebellar hemorrhage. On the MRI, we can see the hemorrhage here. It's very large. Yeah.
For subfield hemorrhage, I already never called that before, but is there a prognostic difference between that versus subarachnoid or hemorrhage? Like, is that something we should be focusing on to differentiate?
Yeah. So the prognosis is poor in subfield hemorrhage because it's not only hemorrhage. There is also this parenchymal component. There's always a parenchymal infarction component too. We don't know why. And when there is loss of the underlying injury is usually greater than what we see. So it's poor prognosis usually. Subarachnoid hemorrhage is, we don't see much in newborns. It's usually secondary to trauma, and it should be a very severe trauma, subarachnoid hemorrhage. Or you need to have a vascular malformation like an aneurysm ruptured. It's very rare in newborns. And most of the time, like we used to call subarachnoid hemorrhage to these hemorrhages before because you never correlate with MRI. And if you don't do an MRI, you don't know if this was subfield hemorrhage. So most likely we were calling these hemorrhages as subarachnoid, although they were not really subarachnoid.
How did they confirm that it was subQ? Was it through like pathologic analysis or?
No, based on MRI. So for example, here, these are the correlate. You can see this, right? So here it's, in not the daily base, but in the research. So it's controversial when they do the histopathology. they claim that it's subpial because under the P amateur, but some authors mention that there is no such space. So yeah. So subdural hematoma is like that too. So in the subdural space, there normally you don't see anything. It's dura is attached to bone, and when there's hemorrhage, it becomes visible. So there's subdural hematoma. But this is different. There is no you don't see the subpial space otherwise. But I don't know. Here it looks like subpial to me, associated with some parenchymal changes. Look at this, for example. It's very confined on the brain ultrasound here, attached over the brain surface. I think they should have found a better name because, as you can see here, there's hemorrhage and this cortex is not normal. So there is this venous infarction here and also hemorrhage over it. So this is usually poor prognosis. You lose these neurons.
Sorry, could you one more time go over on MRI how to distinguish, or how you would distinguish between subpial and subarachnoid hemorrhage?
Oh, you cannot. On the MRI, they look similar. It's how, so in the subpial, there is this parenchymal component right under it. In subarachnoid, you don't have this. And also, when you follow this, it's very confined. It's confined to this area. You don't see others in the other areas. When there's subarachnoid hemorrhage, it's like scattered over the brain surface. This is not like that. It's only confined to one area. And it's a little bit thicker, I believe. So here, for example, thicker.
For the cerebellar hemorrhage, are you also using the term germinal matrix hemorrhage?
Yes, it's used, germinal matrix hemorrhage. Okay. Yes. But for the cerebellum, yeah. It's Barkovich used it, so I use it.
Okay, I have one more question.
Sure.
For the coronal MRI, you have on a prior slide where there was all these. This one.
What's the topic?
Subpial.
Subpial, okay.
Next one. Next one. That one.
Yeah, okay.
Okay, so bottom right.
Sure, yeah.
Subpial is the dark.
Yes.
It's the hypointense
yes.
area, and then the bright is infarct.
Yes, cortex, yeah.
Okay.
Yeah, it's confined to here. If this were a subarachnoid hemorrhage, I would expect to see some more hemorrhage over here, within the other sulci as well. And also, I wouldn't expect to see parenchymal changes under it. If you tell this radiologist, as a general radiologist, subpial hemorrhage, they would say, "Oh no, there is no such thing." No, for sure. I'm pretty sure. This is very new. Yeah. I remember 2 years ago I reported as such, and they called me, and what do you mean subpial hemorrhage? And I tried to explain. Great. So we can give a very short break, like 5 minutes. Then we will continue on PVL. That's going to be our last topic. Then after that, we will do a short quiz game. So please be here in 5 minutes. All right. So we continue with white matter injury of prematurity. So recently, I lectured to NICU, and they also say PVL. PVL is the older vocabulary, and it's incorrect because there is no Malaysia. So it is recommended to use white matter injury of prematurity, but everyone is using PVL. So I don't know. I also use it. It's easier to say it, and everyone understands. So I will use PVL, but the accurate terminology is white matter injury of prematurity. And the underlying mechanism is not known. Just a baby is preterm can have a PVL. And there are three mechanisms to explain this. The first one is lack of autoregulation of blood pressure in preterm infants. So that's why they are prone to it. But the better explanation is oligodendrocyte precursor cells. So they are the precursor cells of oligodendrocytes that produce myelin. And then these precursor cells are located in the periventricular regions in the preterm infant. And they are extremely vulnerable to blood pressure changes and ischemia. So in a preterm infant, when there is ischemic or blood pressure changes, you lose the precursor cells along the ventricles, and that's why you lose myelin. In the term infants, these cells migrate to the periphery, so that's why they are not affected. That's one of the explanation. The other one is the watershed infarction region, so explanation. So in the preterm infants, as you can see on the left side, there are end arteries supplying the periventricular white matter coming from the periphery, and because these are end arteries, there is this is a watershed area, and when there are blood pressure changes, you lose these neurons and you get an infarction in the periventricular areas. In the term infants, there are also end arteries arising from the center, and this watershed area moves peripherally. So in the term infant, you get a peripheral injury pattern. So that's why in the preterm infant we get this. These are the three explanations, but we don't know exactly why this is happening. When we are talking about PVL, white matter injury of prematurity, there are different terms. There is diffuse PVL, and there is focal PVL, and cystic. This focal PVL can be cystic or non-cystic. So this is the explanation of Volpe. So here, this is a cystic PVL, this is a non-cystic PVL, and diffuse involvement and focal involvement. So on the ultrasound, we can see the diffuse involvement as echogenicity in the white matter, and if this is cystic PVL, we can see the cysts. But if it's diffuse and focal but not cystic, which is microscopic, we can't see it. We just see increased echogenicity on the ultrasound. So that's the explanation. So this is also a more detailed slide, but this nicely explains, because everyone thinks of when there is white matter injury, people think that this is all about the cystic PVL. But cystic PVL is actually rare, not the most common, and we see necrosis. It's a real leukomalacia, and there is focal cystic necrosis. And this is the severe form. When there is severe form, we have cystic PVL. And most common clinical presentation is cerebral palsy, and most commonly is spastic diplegia, the bilateral lower extremity involvement. But there are also two other different groups of PVL, and they are more common. The second group is focal microscopic necrosis, and it's also a leukomalacia, and it is non-cystic glial scars. So there is no way you can detect this. You can only detect the cystic PVL on the ultrasound. And there's this one, there's less severe compared to cystic PVL. And we have this diffuse white matter injury pattern, which causes diffuse gliosis. It's very common. And it doesn't present with clinically cerebral palsy, but more cognitive impairments or behavioral, attention, or socializing problems. And this is histopathologically presenting with hypomyelination, gliosis, and decreased white matter mass. And this is more common, and this is the milder form. There is no way you can detect this on the ultrasound. Even on the MRI, you may not detect this. So even a normal MRI cannot exclude white matter injury of prematurity.
Wait, what do you mean we can't detect? Because I feel like I've seen people call, like, with that picture, they call it PBL.
Which one?
Yeah, like there.
PVL?
So you can't see it, so.
So you can't see the cyst. What you see is just
Oh, this is- okay.
So what you see is just diffuse white matter echogenicity.
Okay.
So there is no leukomalacia here. There is no necrosis here. So that's why people say that you can't call it PVL, periventricular leukomalacia, because this is only gliosis. There is no malacia. Malacia is in these two groups, for example.
Gotcha. And then, is there like an internal control you use for the echogenicity? Because sometimes it's really hard to tell. Like, I don't know. If
So,
the machines or something.
there's a classification system by Brias et al. They recommend comparing with the choroid plexus. If it is greater than the choroid plexus, it's abnormal. But in real life, it doesn't work. It's not that easy. Yeah, I will show you some examples. Yeah, okay. So in order to explain this better, we have the Walter White Jr. So he has cystic PBL because he has dysplasia. He has CP, he has dysplasia, but his cognitive functions are well. So he is making more money than we do, right? So his cognitive functions are well, his brain is functioning well, but his lower extremities, he cannot walk nicely. So he has cystic PVL. He's the one with cystic PVL. So what's happening is upper motor neurons and lower motor neurons. Upper motor neurons are coursing through the ventricles. If you remember the homunculus, the nerves innervating the lower leg is coursing along the lateral ventricles. So when we have a PVL injury, it starts from the periventricular white matter. So the first neurons will be the neurons innervating the leg. So the legs are first to be affected, then the trunk, arm, face, and mouth if severe enough. So what happens is when there is loss of the upper motor neuron, we have the hyperstimulation of the lower motor neuron, so increased reflexes, increased muscle tone. And when there is increased muscle tone in the legs, because of the contraction of the gastrocnemius muscles, we see them walking on the toe. That's very common presentation because the gastrocnemius muscles are contracted. In severe cases, we see crossing of the legs because they are contracted. And also we see pathologic reflexes like Babinski reflex, as you can see. And in this child, because it's severe, the upper extremities are also involved. There is fisting of the hand, so it cannot relax the muscles. Fisting of the hand and arms, so all contracted. The babies are spastic. So this is the mechanism. And in the second ultrasound, which is recommended for preterm infants, is for this purpose, to detect the PVL, because initially you don't see the cystic changes. Cystic changes occur within the 4 to 6 weeks. So the main reason of the second ultrasound is to catch the PVL. So this is a typical presentation of PVL. Initially, there is increased echogenicity of the white matter, bilateral symmetric posterior dominant. Then around between 4 to 6 weeks, we start seeing the cystic changes because this is necrosis and this is after phagocytic removal of the necrotic tissue. We see cystic changes filled with CSF. And then these cysts disappear around 3 months and we just see loss of white matter, loss of neurons. So here you can see that there is no white matter. The ventricle is abutting the cortex. So that's why the ventricles are dilated, posteriorly dominant, and we can see this typical indentation over the ventricle because of the indentation of the cortex onto it. MRI is superior. Here is an example. 1 day old, we do the ultrasound. It's normal study. But when we do the MRI on the 3rd day of life, we see infarction, periventricular white matter. So MRI shows, and this is the same patient, 4-year-old. We can see gliosis and loss of white matter. Other examples, 30-weeker, preterm, 4-day-old, we see white matter echogenicity, white matter flaring, which can be normal in a preterm infant. But then around 4 weeks, we start seeing these cysts. And now you can confirm the diagnosis of PVL. And then around 3 months, these cysts are resolved, mild. There is resultant dilatation of the ventricles. And 1-year-old, what we see is ex vacuo dilatation of the ventricles and loss of white matter. So you should always be able to see the same amount of white matter posteriorly as compared to anterior. So anterior, there is this much white matter, but posteriorly you don't see it. So you lost white matter. And the most common cause in a preterm infant of losing white matter is PVR. So even if I don't give you any clinical history, you see this MRI, the first diagnosis you should think of is PVL. Another example, typical scenario, 1 day old, some echogenic white matter. So the recommendation is compare with the choroid plexus. If it is brighter than the adjacent choroid plexus, it's abnormal. In this case, it is not. So it is normal. It's normal compared to choroid plexus. Then 4-week-old, we start seeing the cysts. So it is PVR. So the pathology starts initially, right? So it was also necrotic here, but we are not seeing it. Then when we start the cystic changes, we confirm the diagnosis. And this is the MRI correlation. 5-week-old, we can see the cystic changes, periventricular, typically bilateral, posterior dominant, and periventricular. Another example, I'm showing you lots of examples because this is important. 6-week-old, 6-day-old actually, I think this is my mistake, 26-weeker. And then 8-week-old, we start seeing the cysts. I don't know why they waited 6 weeks to do the second ultrasound, but it is not uncommon that they don't follow the timelines for the ultrasounds. And then around 12 weeks, we still see some cystic changes and gliosis, and they did ultrasound, and initially there is loss of white matter, ex vacuo dilatation of the lateral ventricles, and undulating contours of the lateral ventricles, typical. Posterior dominant, there is almost none white matter left posteriorly. There is some white matter anteriorly. Another example, 4-day-old echogenic white matter, 15-day-old still echogenic. So if it lasts more than 1 week, it is suspicious. It should resolve, or it shouldn't be more intense. So around 23 days, similar, 30 days, still no cyst. 5 weeks, still no cyst. 6 weeks, still no cyst. But repeat ultrasound around 8 weeks, we see the cysts. So when you see the cysts, then it's PVL. You confirm the diagnosis. But as I told you, cystic PVL is rare. The diffuse PVL is more common, and diffuse PVL we can't really diagnose by ultrasound because the ultrasound diagnosis is based on showing the cysts. And as in this case, the cysts appeared around 8 weeks. So according to our timelines, we do the ultrasound between 4 to 6 weeks. If you follow that, you will miss this PVL. The problem is, clinically, they are not able to make the diagnosis. They are dependent on the ultrasound because the babies don't move their legs until 6 months of age much. So they can't really assess, but around 6 months, they start moving their legs. And when they realize that their legs are spastic, they can move freely, then they are like, okay, this must be PVL, let's do an MRI. But then they will miss the diagnosis initially. Another example, 3-day-old, 13-day-old, it looks normal. 5-week-old, we start seeing the cystic changes, 9-week-old, 11-week-old, and this is the MRI correlation of the cyst. Posterior dominant, periventricular, bilateral, grossly symmetric. This is the classification done by Brias et al. Maybe 50 years ago. No. And grade 1, periventricular echogenicity lasting over 7 days. There are no cysts at this stage. This is the example I could find. Grade 3, evolving into focal cystic lesions. Here we start seeing some cystic changes. Grade 3 is evolving into extensive periventricular cystic lesions, not focal, but extensive. So just like this one. And grade 4 is evolving into periventricular and subcortical white matter cystic lesions, more extensive cystic lesions, both involving the periventricular, also subcortical white matter. So this is the classification system. So the prognosis is based on these grades. This is the worst prognosis. This is the best prognosis. And also it gives you an idea regarding the occurrence of the cysts. When it's grade 2, cysts usually occur after 4 weeks of life. If it's grade 3, the cysts occur earlier, around 2 to 3 weeks of life. Okay, so if I ask you if this could be white matter injury of prematurity, there is 2 ultrasound studies on the 3-day-old. There is intraventricular hemorrhage and some white matter echogenicity, bilateral symmetric, posterior dominant. And also this is the same ultrasound around the same patient, 5-week-old. There is still some increased echogenicity. Some echogenic areas are more focal, but there are no cystic changes. Could this be a PVL or something else? So what is the other differential? So we did an MRI. MRI shows hemorrhagic lesions, periventricular hemorrhagic lesions. So this is not PVL. PVL is by definition not hemorrhagic. Histopathologically, there is no hemorrhage in PVL. So if you see hemorrhage, it's not PVL. So it's periventricular hemorrhagic infarction. So this is, I told you in germinal matrix hemorrhage, grade 4 is equal to periventricular hemorrhagic infarction. And it may be confused with white matter injury of prematurity. How do we differentiate? So PVL is usually bilateral, symmetric, and presents with ill-defined spread lesions and may not be associated with germinal matrix hemorrhage, not all the time. Usually they may, but may not. Periventricular hemorrhagic infarction, on the other hand, can be unilateral or bilateral, usually asymmetric, and confined fan-shaped lesion, not spread, and always associated with germinal matrix hemorrhage or intraventricular hemorrhage, just to differentiate them. Yeah, so this was the prematurity part. So I am finishing my lecture by giving you some examples of other indications of cranial ultrasound. How we use Doppler, for example. Doppler is also very useful. But before I start, are there any questions regarding PVL? It's a very popular topic. The neonatologists will keep asking you questions regarding this.
Okay, Dr. Yikilmaz, do you just offer both in the differential then? Paraventricular hemorrhagic infarction and white matter injury?
Yeah, it's in the differential, but I think it's possible to differentiate. Most of the time it's possible. Yeah.
At what age do you stop seeing PVL? Like, is it not seen at all in term beings? Like,
Yeah. I mean, it's in medicine, nothing is never, right? But maybe, but it's typically in preterm infant. We never, I don't remember a case, but I think it's still possible. Yeah. It's related to the age. The early, the worse. So it is always recommended not to have preterm babies, because when the baby is born preterm, there are a lot of other pathologies too, right? It's not only the brain. So it's affecting the lungs. So you have RDS. It's affecting the eyes. You have the premature retinopathy. And it affects the kidneys. Kidneys become echogenic. They appear echogenic. You have problems in the kidneys. It affects bowel. You have necrotizing enterocolitis. And you don't need anything else. So just being premature can give you all of these. And these babies suffer in the NICU for months, all their lives maybe. And you may think that, okay, the technology is improving, NICU units are better, we are doing better ultrasounds, better MRIs, so we should be decreasing the HIE, premature complications. No, it's actually increasing in number. And even the NICU units are not enough because the baby is born earlier because of IVF treatments and others. They born early, even 20 week. They born halfway and 21 week, and they survive. And then because in the past we were just losing them. They wouldn't survive. Today they survive, and we are dealing with their complications, premature complications. So it is more common nowadays. Okay, so Doppler is not routine. I used to scan myself in Turkey. Radiologists would scan, so I was doing Doppler all the time. I found it very useful. But here, because the sonographers are doing, they don't do Doppler. They don't feel confident, and it's always problematic to ask them to do Doppler. So we are not doing it routinely. Even we are not doing the assessment of the superior sagittal sinus routinely. If you see some sinus images, don't report it. We are just getting those images to show you the extraaxial CSF spaces, not for the superior sagittal sinus. So because the assessment of the superior sagittal sinus might be difficult, if you compress your probe a little bit too much, then you may think that it's obstructed, but it's not. Sometimes you can see an echogenic content and flowing slowly, stagnant flow. It's normal in the neonates because of high hematocrit levels or hypovolemia, but this is not considered as a thrombus. As you can see, you can confirm the patency. This is a patent superior sagittal sinus on the coronal and sagittal, and these are the draining veins. And this is a sinus thrombosis on the sagittal and coronal. There is no flow, and you can see the echogenic or heterogeneous clot in that. And you can also see the other veins too, as I told you, transverse sinus, straight sinus, basal veins, and superior sagittal sinus. How do we use it? For example, in this case, on the MRI, we saw this sigmoid sinus on the left, like T2 hyperintense compared to normal right side. We thought this could be a thrombus. It looks like a thrombus. Even on the coronal, it's hyperintense. It looks like thrombus. So in this case, we can call the patient back, sedate again, and repeat the MRI, inject some contrast, and confirm. Or you can go to bedside and do this Doppler, limited Doppler, put your probe over the sinus and check for the patency of the sigmoid sinus as we did. You can confirm with spectral imaging. So it's patent, it's just an artifact. So Doppler can save repeating the MRI study. So this is also used. We used to use it more often. Patent ductus arteriosus. So normally, normal flow pattern is like that. Low resistance flow pattern because you need flow in the brain, just like kidneys. So this is the normal flow pattern. There's always flow into the brain during the systole, during the diastole. And here, when there is patent ductus arteriosus, there is reversed and diastolic flow. During the diastole, the flow is reversed. So it is flowing away from the brain. So we don't see that normally. And when you see that, there are two things. First, the baby has brain death. There is no flow. Or second is patent ductus arteriosus. So that makes more sense in a healthy child. And when you treat it, then you can follow up by Doppler too. But in this one, there's brain death. You do a Doppler, you see flow in the carotid arteries, but there is no flow in the brain. So this is the same idea as CT. And then if you get any flow, the flow will be very dampened flow, the peak systolic velocities are low. Compared to the normal pattern, you see this much monophasic flow, and this is brain death usually, or very poor prognosis. And this Doppler ultrasound was introduced for post-hemorrhagic ventriculomegaly. It's called compression ultrasound by George Taylor at Boston Children's. What he did was he first tried this in the in animal, experimentally in the animals, then applied it to children, and it worked very well. What he did was when there is post-ventricular hemorrhagic dilatation, we decide if we shunt or not. So this helps for the management of shunting. So you put your probe over the anterior fontanelle, then you compress the brain slightly for 3 to 5 seconds. So when you compress it, you compress the anterior pericallosal branch of the anterior cerebral artery, and you push it, and you change the flow pattern. So if it is normal, you cannot really compress the artery well because there is no increased pressure in the brain parenchyma. You cannot transmit the pressure with your probe. But if there is already increased intracranial pressure, you can transmit the pressure to the artery, and you can actually compress the artery, and you can change the flow pattern by compression. So if you can change the flow pattern, if you can change the RI value over 30%, it means that there is increased intracranial pressure, and it means that this patient will benefit from shunting. For example, here, that's the baseline, that's ventriculomegaly. We don't know if it is increased intracranial pressure or just ex-vacuodilatation. We do this study, we compress. When we compress, you change the flow pattern, you obstruct the anterior cerebral artery, and it means that you are changing the RI value significantly. It means that there is increased intracranial pressure, and the patient will benefit from shunting. That's the idea. And other than that, we use ultrasound for the detection of congenital anomalies. Just to give you examples, this is a cerebellar hypoplasia, pontocerebellar hypoplasia case on the MRI, small cerebellum, and on the ultrasound. Vein of Galen malformation here, cystic anechoic structure filled with color, yin-yang appearance. You can see arachnoid cysts on the ultrasound and on the MRI, and also ageness of corpus callosum on the sagittal. There is no corpus callosum. There is digitation of the cingulate gyrus, and there is no corpus callosum. This is the cingulate gyrus embodying the ventricles. Infections for the CMV is the most common. In CMV, we can see pseudocysts or germinolytic cysts. This is the MRI correlation. As you can see here, subtated complex cysts, and on the ultrasound, these are the cysts. And we can see calcifications, usually periventricular in CMV, not always with shadow. And periventricular cysts, they are bilateral, symmetric, adjacent to the atriums and temporal horns. And there's also polymicrogyria on the MRI, but you can never see it on the ultrasound. And this is associated with lenticulostriate vasculopathy here. In bacterial infections, there is usually an abnormal finding on the ultrasound. This can be leptomeningeal thickening. As you can see here, there's thickened leptomeninges. And here there's pus over the meninges, and we can detect it with increased vascularity. We can see ventriculitis with debris within the ventricles associated with dilatation and thickening of the wall with ventriculitis, thickening and echogenicity of the wall. And you can have a subdural empyema, which is a true urgency. Here, an extraaxial complex fluid collection. And abscesses, we can see them. This was due to a Citrobacter infection. There's intraparenchymal abscess and with restricted diffusion and rim enhancement. And finally, we can see brain tumors. The children may be born with brain tumors. It is not common, but time to time we see these children. Benign, these are the most common benign and malignant tumors in the brain. This can be just an example, a lipoma with corpus, dysgenesis of the corpus callosum, agenesis of the corpus callosum here. And lipoma appears as a hypoechoic structure in the midline. And this is a hemangioblastoma in the newborn, in the cerebellum. And this is a choroid plexus papilloma with vascularity in the lesion. And this is the MRI correlation. So despite tremendous advances in MRI, cranial ultrasound is still vital for critically ill infants in NICU. Use alternative fontanelles and Doppler whenever possible, and be familiar with common variants. All preterm infants under 32 weeks of gestational age should be routinely screened for possible complications of prematurity. The most common indications are white matter injury of prematurity, germinal matrix hemorrhage, and post-hemorrhagic ventriculomegaly. And thank you for listening. And I can get questions here. If you're not asking questions, I will ask you questions.
Quick question.
Sure.
For like TBL, what would be the findings with like TBL, like in adults who survive? So that
Oh, same, just like this guy. So if there's cystic PBL, the less common form, most of the time I see spastic deparesis, so they can still walk, but they walk on their toes, and they get botulismus injections to the muscles, so they get relief, but they need to do it routinely. So you may not even realize if it's mild. Or in severe cases, they use stretchers. But most commonly, they call it ADHD pattern, spectrum, autism spectrum. So most of these patients are in this group, like some cognitive disability. And if you even on the MRI, you may not see anything.
So MRI might be like unremarkable.
Yeah, MRI is helpful in this. If you see white matter changes, but in the long term, it's just some gliosis, some white matter loss, some gliotic foci, but it may not give you. I think it's important to learn the clinical history. Did you born preterm? I think it's possible nowadays. You can see how they were born. At my time, it wasn't possible. There was no PACS, no electronic patient information charts. But nowadays, you can access. If somebody is born preterm, you know it. So, all right. Are you guys ready? Okay, you should. So I would recommend you to use your laptops. It's better on the laptops. Cell phones are a little bit too small, but it's okay. So I will stop sharing here. All right. 10 questions, 10 multiple choice questions, and typically takes 10 minutes. If you answer faster, you get higher points. So your score will be between 50 and 100 based on your timing. And some questions at the end, there is more than one, there may be more than one correct answer. Initially, I think it's only one. And yeah, so I think you know this, right? We did this before. So I will start with the first question. Initially, I will show you the images. I will give you some time. Then you will have 20 seconds to answer. First question. Name the anatomical structure shown by the arrow. And first, we will wait for you guys to attend again. If there's still some people who did not. Okay. Let's see. Okay, everyone is here, right? Okay, so we are starting. For the first question, you have 20 seconds. Okay. Cavum septum pellucidum, nice. Okay, the most incorrect answer would be third ventricle, and some people did that. Four of you did that. So third ventricle is below here. Below, cavum is between the frontal horns. That's the cavum. Okay, good. So second question. Okay, let's see. Who is the user? Just user? iPhone 3? Come on, guys. Who? Oh, okay, great. Great. Okay, second. So see, PGY2. Okay. This PGY2 is like, I'm only PGY2 as an excuse, you know. I'm lost, but it's okay. Good. Second question. What is the grade of the germinal matrix hemorrhage? Look at the images carefully. I will give you 20 seconds. Now. Okay, everyone answered. Grade 2. Yes. it is grade 2. Grade 2s are uncommon. There is hemorrhage in the ventricles, but there is no dilatation of the ventricles. Okay, great. All right, user. Hydrocephalus, Vinette. Okay, good. Who's hydrocephalus? Okay. Third question. So in this case, there are 2 ultrasounds of the same patient on the 10th day of life and 4th week of life. What is your diagnosis? You have 20 seconds to answer. Let's see. Okay, white matter injury of prematurity, correct. Also known as PVL, because we are seeing bilateral symmetric cystic changes, periventricular and posterior dominant. And user hydrocephalus going on. iPhone 3. I wanna call this iPhone 3. Am I calling? Okay. Hydrocephalus is going well. Crispy chicken, bingo. I know who this is. With the mustache. Mustache guy. Cranial.
Why are you a lawyer?
Oh, I don't know. Asking you, just like,
Okay. Great. Question 4. What is your diagnosis in this patient? The patient has coronal ultrasound images as well as parasagittal images from the right side and left side. Ready? Carefully review the images. I see a cyst, but what kind of cyst? You have 20 seconds. Let's see. Connatal cyst. Nice. We have only one. Only one. Who didn't know? Okay. iPhone 3. That's tired residents. Who's tired? Crispy chicken. Yeah. Who's crispy chicken, by the way?
Oh, how snappy in the middle. I said I couldn't write sandwich, there were 2 big words. Sorry. I thought it was snappy.
PVL, okay. Yeah. Alex.
The first question did not go through.
Yeah. But there's still hope. Okay.
I'll speak.
They are equal. iPhone 3 and hydrocephalus is equal. Nice. 10 points. Okay. Okay. Alex, I will give you 30 points. So you're not lost anymore. You're now 17. Because I'm rotating with him, this week, so he's helping me a lot for the reports. I had to do it. Okay, 5th question. What is your diagnosis? This patient had 3 ultrasounds at 1 week old, 3 week old, and 3 month old. Please review carefully. I am giving you 20 seconds to respond. Let's see. Nice. Wow. Everyone knew it. Nice. The lecture worked out. So, wow. Tired is rising. iPhone 3. Crispy chicken. Alex. Alex. You knew it. You got 79 points. But because everyone got it, it didn't work out. Yeah. Good job. 6th question. What is the most likely diagnosis in this newborn with coronal and parasagittal ultrasound images with Doppler? You have 20 seconds. Subpale hemorrhage, nice. Most of you did. Infarction, tumor, subdural hematoma. Subdural hematoma, yeah, I didn't show you that.
Is there an infarction with the hemorrhage too? Or this is just the hemorrhage?
This is, it's called subpale hemorrhage, but it's called hemorrhage. But there's always associated a venous infarction component to it.
So the bright thing we're seeing.
It's hemorrhage. It's hemorrhage. Yes. On the ultrasound, we see the hemorrhage. If you do an MRI, you see the infarction. Yeah. So great. Let's see who did well. Oh, you knew it, crispy chicken. Okay.
No, I didn't see the infarction until after.
Oh, okay. Okay. Good. Tired. Okay. Nice. Minette, user, crispy chicken, iPhone 3. Hydrocephalus. Alex, come on, Alex. If the medical students win, I would know. How are you guys doing?
Number 11.
11? Oh, not bad. Oh, not bad. Okay. Come on, guys. We have a PGY2 here. Come on. All right. Last 3 questions. Question 7. This patient is 41 weeker, so not a preterm. And you are seeing the ultrasound images on the top row and MRI images in the bottom. And what is your diagnosis? You have 20 seconds. Great. Wow, almost all germinal cysts. Let's see. Tired minute, crispy chicken, iPhone. Wow. I think the questions are too easy. Everyone.
No, we're just all paying attention.
Yeah, great. Yeah, good. Because each time I lectured on germinal lytic cyst, everyone is confused. They keep asking me weird questions. But now I think you got it, which is good. Yeah, very good. Last 2 questions. Question 8. In this question, there will be more than one correct answer. Or, oh no, not this one. Not this one. Last 3 questions actually. Not this one. This is the ultrasound and MRI images of the same patients, which I showed you during the lecture. And what is your diagnosis? Let's see if you listen to lecture carefully or not. I see periventricular cysts, bilateral symmetric. What happened there? Good. Come on. It was CMV. I showed you this case. There are bilateral cystic cysts adjacent to the temporal horns and occipital horns, and germinal lytic cysts and lenticulostrate vasculopathy. These all you can see them in CMV infection. Great. So let's see. Oh, who is AW? Oh. Oh. Bob. Bob is right. AW. Yeah, great. iPhone. Bingo. Alex. Come on, Alex. You can still do it. Yeah. Okay. Last 2 questions. And question 9. There are 4 different patients here. I showed you these cases during the lecture. Select the ones with intraventricular hemorrhage. They are all different patients. You can, you can select more than one or just one. We don't know. Review carefully if you see any hemorrhage. Okay, so we are starting You have 20 seconds. But you still get points. You still get points. Even if you name only one, you still get points. So they're all intraventricular hemorrhage. All of them. I showed you all these cases. Even though they're tiny, they're all intraventricular hemorrhage. And vignettes, okay. Tired, AW, Bob, user, crispy chicken, hydrocephalus, okay. Great, okay, so last question. Again, you can give more than, this is actually not the question, this is the confirmation. If you don't believe me, I'm showing you the MRI correlation. That's the hemorrhage here. That's the hemorrhage here, and hemorrhage. I think I just didn't show you the last one, D. That's also hemorrhage. Okay, so last question is there are 5 different patients and you are going to select the one or the ones that is a normal variant or does not have any clinical significance. Review carefully. I put the arrows for the area of interest. I am specifically asking for those structures. Are they normal or abnormal? Could be, yeah. At least one. You can check your slides, notes. Oh, you didn't know? You have 20 seconds, you can't really. Okay, starting now. Ready? All of them, all of them. Okay, yeah, I think I showed you all of them. The first one is pons on the coronal view. It's not hemorrhage. The second one is the hump of the choroid plexus. The third one is the internal cerebral vein. Fourth one is the septal vein within the cavum, septum pellucidum. And the last one is simple subdural collections. So let's look at the results. And the winner is tired. 900 points. Great job. Unet, the second. Who's AW again? Oh, Nice. you were quiet, but you know, like you did very well. 30 points, okay. I can give you 30 points. It didn't change. Sorry. Okay, great. Let's see the rest. You can see. So Bob, Ford, hydrocephalus fit, user 6, crispy chicken 7, iPhone 8, Y 9. Who was Y? Yeah, look at that. Cranium is 10 and the rest. Alex, you're 16th. Very steady, very steady. Good job. Thank you guys. You did well.
Thank you.
Yeah.
Yeah, don't absent, so don't forget to fill out the details.
What's that?
You want a detail? It's like a round email. We have a round email.
Round?
We can fill out like an evaluation.
Oh yeah, please, yeah, do it. Give me 5 stars.
Oh, where was it? Are we on?
Oh, yeah.